Hello, my name is Kaarlo Simojoki. I'm working in Finland at the A-Clinic Foundation, where we treat around 25,000 addicted patients per year. And today the issue is how you could enhance opioid substitution treatment by using new methods which have been used and studied in Finland for a while. Opioid addiction and its treatment is a theme which I have been doing my PhD a few years ago, and the theme of the PhD was how to enhance opioid dependence treatment and to get better outcomes. So today I'm trying to give you a presentation about enhancing opioid substitution treatments by using new methods and new ways of doing treatment, especially with the urine testing. Shortly, a few words about opioid dependence. Why it is important to keep in mind that we have to give the chance of using new methods and to give the possibility of getting better outcomes. It's a chronic relapsing condition, and that's very important to remember because the treatment will last for years and for most of the patients a lifelong time treatment. What is very important is that during the treatment and because of the nature of the disease, patients have compulsive drug seeking and also abuse. And therefore it is very important that especially in the first years of treatment, we do use urine testing to get patients for not using or abusing other drugs than the ones we have prescribing from the clinic. Opioid dependence and opioid abuse has been rising in Europe and all parts of the world. For example, in Finland, when we look at the data from the last 10-15 years, we can see that from 2005 to 2012, the number of opioid abusers have been rising from 5,000 to almost 15,000. That's a huge rise. And many of them are still, for example, in work or have not yet been totally dropped out from society. So there are new groups coming into the system. Opioid dependence also, as any substance dependency, has two sides. One is the physical dependence, which we treat with the medication. And the more important side, actually, in the end, is the psychological addiction, where we have to change the behavior of the patient. And part of this process, we will have to use urine testing to give the patients feedback and, on the other side, to control their compulsivity. Why urine testing? Why it is important? First of all, it is important because it gives us the knowledge what the patient has been using or is using, and that gives us the possibility to give him safe treatment also in the medical sense, so that we know which medications we can use. It is important to do it regularly so that we get data, but on the other side also randomly, so that the patient has always the back thought, do I use or do I not use, because he or she doesn't know when we will do a urine test. And that means that we will change their behavior with the abuse of other drugs. We can also use urine testing as part of measuring the compliance, meaning if opioid dependence patients, for example, stop using opioids, look at treatment outcomes, and can also ensure the safe administration of medication, as I said before. That's very important in OMT. We also have to use it in other areas, like, for example, child welfare, occupational health, and in prisons, of course, where it's very important that no drugs come into the system. But in every case, with the methods we use nowadays, there is the question of how we can ensure that the urine being analyzed can undoubtedly be conducted to the correct person. How do we know that this urine has been given by that patient? So in most cases nowadays, to ensure this, the urine testing situation is very strictly controlled, which can be quite humiliating for the patient, and on the other hand, it also ties up the resources of the clinic, and they can do it to a very big extent. And that, of course, in the end, is not very good for treatment. This strict control also may affect negatively the mutual trust between the patient and the clinic and the personnel, and in the end, lower the patient compliance. what are the main problems with the methods we use nowadays? We have, in many places, use rapid tests. The good side is that we get quick results. It takes a few minutes. They do not cost very much, and they detect a lot of various groups of substances. The problems are that you can falsificate these tests quite easily. There's a lot of cross-reactivity, which is or will become an even bigger theme because patients are using opioid painkillers, and there is a lot of errors. Even 5 to 30% of the results are wrong. That means they are wrong positives, so that you get a positive result although the patient hasn't used anything, or you get a false negative, which means that the patient is using something and you don't not detect that. Both cases are not good for the patient and the treatment. And you can't use these because of this for legal purposes, for example. So with child welfare, you have a problem in that case. It also ties up a lot of staff work time because for the patients, it's hard often to give the urine test if someone is standing beside you. So it might take 4 hours. We have patients, for example, or had patients, because we're now using the Ruma method, which had to be supervised for up to 4 hours. That takes a lot of resources, and that's not very good for the resources, but it's also a bad thing for the therapeutic relationship. So what we did conclude was that, okay, these rapid tests are acceptable for screening, and especially if we need them or the results very fast. But then we had to think about something else. We have found a new marker method done by the Ruma company from Germany, which makes the supervision unnecessary. So, of course, we were very interested in this method and thought, how can that work? Shortly, the chemistry behind that is that the urine will be labeled by a modified sugar, and that will be taken orally. It's very fast excreted through the kidneys, and it does not occur normally in the urine. So that means that we just have to supervise the giving of this marker. We wanted to test it. We want to make a study about it because we wanted to see how this works in OMT and how you can use it in OMT to enhance the compliance of patients, and on the other hand also get better use of the resources we have. This study has been published. You can see it there, where you can find it. And I will go through some of the key points we have found in that study. The first thing was what we did actually, and which was a new thing, that we gave the patients the possibility to give their urine sample at home, where they live anyway. And because the urine, if it is held in cold conditions, can be kept at home up to 2 weeks, the marker in itself, done by the Ruma company, does not or is not affected by this time. So we said, okay, here you have your sample, you take the marker now, supervised at the clinic, and then you can go home. We gave out, for example, over 100 samples to patients who were giving it at home, and 98% or 98 of these were given back. So it means almost 100%. Actually, the ones of you which were missing were samples which were eaten by a dog of a patient. So in the end, we can say that 100% came back. And you can imagine how much easier it was for the patients and for the clinic to have this possibility of urine sample taking or giving at home. Then we of course asked the patients, what do they think about this new method? And as you can imagine, when we compared 2 groups, where one had this new method, the Ruma system method, and the other had this old supervised system, even in the group which was not allowed to have this new marker system, the majority of patients would have liked to switch to the new marker group. Then we of course ask the patients, what do they think about this new method? And as you can imagine, when we compared two groups, where one had this new method, the Ruma system method, and the other had this old supervised system, even in the group which was not allowed to have this new marker system, the majority of patients would have liked to switch to the new marker group because they saw how easy it is. You just take the marker, which is supervised, then you're not allowed to urine for about 30 minutes, which is actually not a problem for the patients, and then you can give the urine test without any supervision or at home or wherever it's the best place for the patient. So also in the marker group, most of the patients would have liked to keep this method in use. Some patients did prefer the supervised method. I will come to that back a little bit later. Then of course we wanted to know what the personnel is thinking about this new method. So we gave them also the possibility to answer some questions that was related to time using, to the therapeutical relationship and other ethical issues also. And for example, most of the personnel said that the supervised method had a negative impact on the therapeutic relationship, and especially in that case that you have to use the same personnel for taking the urine tests and on the other hand also to work in a therapeutic relationship with the patient, which is understandable. So they were all happy that they could switch over to the marker system. If you look at the time saving, and that's really a big issue because we have a lot of patients and the number will rise, that the time saving estimated by the personnel who actually is doing the urine testing was between 50 and 70%. So that's a huge number of time which has been saved by the new marker method. What about the some patients who didn't want to take the new marker system? They actually are a small subgroup which have mainly some psychiatric comorbidities, for example, instability or high insecurity, borderline patients, and they might need the supervision to keep their own mental wellness in a good way. So that means you have to know your patients and you have to think, okay, for these patients we can use the marker method, for the rest we can or should still use a supervised method, but that can change, of course, when time is passing on. When we need instant results, sometimes it is better, for example, to use saliva tests because with the urine testing, as you know, or as I stated before, you will take time when you have to supervise it. So in the end, what we could conclude from this study and from the clinical issue was that the new marker test would and should actually be the first choice in most of the cases of patients. And after this study, we have been using the marker test since, and when we, for example, had some times when we, due to some out-clinical issues, couldn't use it, the patients were very unhappy and demanded to have the marker system back. So at our clinics, we're very happy with this system and it's working very well. In conclusion, we can say that the new marker test seems and is actually in many aspects favored compared to the traditional supervised urine testing. The patients do prefer it. The personnel does prefer it, and that means that the compliance of patients also did rise during this process of using the new Ruma marker system. And one reason, as I said, is, for example, the better privacy of patients. But when we also looked at the financial side of that, because that's really a big issue nowadays, is that in average, for example, at the clinic where we did this test, we take about 25 to 35 urine tests per year per patient. If we, for example, due to the study, counted that we use, for example, 40 minutes per patient and per urine sample, and for 70 patients, that means around 1,600 hours alone for urine testing. If we drop it down to 20 minutes, like we did with the new marker system, it's half of that, 817 hours. So it means that 800 hours per year are freed to work in a therapeutical manner with the patients. And that, of course, in the end will be significant if you think about the outcomes of treatment. It's very important that you have the time to work with patients. Urine testing is only one part of the treatment. The therapeutical work is that which changes the way the patient is behaving and in the end is the reason for good outcomes. When we also take the financial issues in account, we have to say that this with no doubt will affect positively on the clinical treatment outcomes. When we looked at a 12-month period, we gave out over 480 tests during that period. Almost all of them had the marker. It was found. That means that the patients did not try to make any fool with that. And the number of other drugs being abused was very little. Under 25 amphetamines, cannabis 65 times. The big problem was benzodiazepines, but that's normal in Finland, and these are patients in the first year of treatment, and only 9 cases of opioids. So it means that when you have a method which works well, saves times, and which also makes it harder to give fails urine test, you will get better outcomes. And that I can show also with the next slide, where you see that the blue one means that the patient is not using any other drugs than the ones prescribed in the clinic. The red one means that they are abusing now and then, and the yellow one that they abuse almost every day. And after 2 years of treatment, you see that almost 2/3 of the patients do not use at all any other drugs. The main drug they are still abusing at that point is cannabis now and then. So it means when you do a very coherent treatment system and combine new methods, you will find a way to enhance your treatment outcomes. It is very important to keep always in mind also with the urine testing and therapeutical work that each patient has a unique constellation of factors that impacts their treatment. So you have to find the right way of urine sampling, the right way of medication, and the right way of give the patient the treatment, to give the patient an integrated, flexible, and sufficient long-lasting treatment. And because OMT is very long-lasting, it's important to also look at the financial sides, which I showed you before. In the end, and this is where I will stop, remember that urine testing is an important part. It's not the most important, but it's very important. It has a big effect on the relationship between the patient and the clinic. And you can take a method which will save time, which will make the outcomes better, and which has a positive effect on the therapeutical relationship. Then you will get better results, and you will have the possibility to give the patient treatments which is just tailored for that certain one patient, and that will even more enhance the outcomes. Thank you.